In 1860, the United States had 55,000 doctors for a population of over 31 million people. That's roughly 175 physicians per 100,000 people, half the ratio we have today. Most of them worked alone. They made house calls on horseback or on foot, sometimes traveling 10 or 15 miles to reach a single patient. They carried leather bags filled with basic instruments, a stethoscope, a thermometer if they could afford one, lancets for bloodletting, a few bottles of morphine and quinine. Their annual income averaged between $1,200 and $2,000, about $35,000 to $60,000 in today's terms. And in rural areas, they were often paid in goods instead of money. They had no antibiotics, no x-rays. Reliable anesthesia didn't exist until the 1860s. Germ theory was still controversial. Hospitals were avoided because of poor sanitation and high infection rates, and yet these doctors were expected to treat everything: fractures, infected wounds, cholera, tuberculosis, typhoid, difficult childbirths. How did they manage? What was it actually like to practice medicine when nearly every serious illness could kill, when diagnosis depended on observation and guesswork, and when you were the only person a community could turn to? More importantly, what happened to this profession? Why did the country doctor, once the backbone of American healthcare, disappear? This is the story of a medical system built on individual responsibility, limited knowledge, and physical endurance. A profession that transformed entirely within a single generation and left almost nothing behind. To understand what these doctors faced, you first have to understand how they became doctors in the first place. In 1850, there was no single path into medicine. Some men attended formal medical schools, institutions that might run for just 4 months a year, with the lectures repeated verbatim in the second year. Others learned through apprenticeship, spending 2 or 3 years shadowing an established physician, mixing remedies, holding instruments during amputations, and absorbing knowledge through observation. And some simply hung a shingle and called themselves doctors, because in many states, there were no laws to stop them. Licensing was inconsistent. Standards were almost non-existent. A man could graduate from a medical college in Ohio with only 6 months of coursework and no clinical training whatsoever. The American Medical Association, founded in 1847, tried to bring order to the chaos, but it would take decades before medical education resembled anything we'd recognize today. What this meant, practically, was that the quality of care varied wildly. A doctor in Boston might have studied anatomy in Europe and kept up with the latest journals. A doctor in rural Missouri might still be practicing bloodletting and dosing patients with mercury-based purgatives that did more harm than good. But here's the thing. Even the best-trained physicians were working in the dark. The stethoscope had been invented in 1816, but many doctors didn't own one until mid-century. The thermometer wasn't widely used until the 1870s. Blood pressure cuffs came later still. Microscopes existed, but understanding what you were looking at under the lens required knowledge that most schools didn't teach. And then there was surgery. Before the widespread adoption of ether and chloroform in the 1860s, operations were brutal, agonizing procedures performed on kitchen tables. Speed was everything. A skilled surgeon could amputate a limb in under 2 minutes, not because he wanted to, but because the patient was awake, screaming, and at risk of dying from shock. This was the foundation. This was what a 19th-century doctor carried with him. Incomplete training, improvised tools, and the unshakable expectation that he would somehow save lives anyway. Dawn breaks over a small town in upstate New York, 1880. The doctor wakes to a knock at his door. A farmer's son, breathless, saying his sister can't stop coughing blood. It's the third call this week. Tuberculosis, most likely. There's no cure, but the family expects him to come anyway. He dresses in his dark wool suit, the uniform of respectability, and picks up his leather medical bag. Inside, a stethoscope, a few packets of quinine for fever, laudanum for pain, a scalpel, bandages, a syringe, maybe a thermometer, if he's kept up with the times. He steps outside into the cold and begins the journey on foot, or if he's fortunate, on horseback. This was the rhythm of a country doctor's life: constant movement, endless availability, and isolation. Most doctors worked alone. There were no group practices, no shifts, no coverage. If you were the only physician within 10 miles, you were on call every hour of every day. A typical week might include 30 house calls, spread across farms and homesteads separated by miles of dirt roads. In winter, those roads turned to mud or froze solid. In summer, dust choked the air. The doctor traveled through it all. Inside each home, he worked by lamplight or candlelight. He examined patients in their beds, often surrounded by family members who had their own ideas about what was wrong and what should be done. He had to be part scientist, part negotiator. If he recommended a treatment the family didn't trust, they might ignore him entirely. If he failed to save a patient, word spread quickly. The tools were simple, but the decisions were not. A high fever could mean typhoid, malaria, or any number of infections. A persistent cough could be tuberculosis, pneumonia, or lung disease from years of factory work. Without lab tests or imaging, diagnosis relied on observation, touch, smell, and instinct. The doctor listened to the chest, felt the pulse, checked the tongue, and made his best guess. And then there was childbirth. Doctors were increasingly called to assist with difficult deliveries, a role traditionally held by midwives. But in an era before antiseptics became standard practice, the doctor's own hands, unwashed after examining other patients, could carry infection from one house to the next. Childbed fever killed thousands of women every year, and many doctors didn't yet understand why. By evening, the doctor returned home, if he returned at all. Sometimes he stayed overnight at a patient's bedside, waiting to see if a fever would break or if death would come first. In 1878, a yellow fever epidemic swept through the Mississippi Valley. In Memphis alone, more than 5,000 people died in a matter of weeks. The city's doctors stayed. They moved from house to house, treating patients they knew they couldn't save, while others fled in panic. Many of those physicians contracted the disease themselves. Some survived, many didn't. This was not an exception. This was the job. To be a doctor in the 19th century meant constant exposure to infectious disease with no real protection. Cholera, typhoid, diphtheria, scarlet fever, smallpox. These weren't distant threats. They were the daily reality of practice. A doctor might see a patient with tuberculosis in the morning and deliver a baby in the afternoon, carrying bacteria from one home to the next without knowing it. Hand washing wasn't standard until the late 1800s, even after Ignaz Semmelweis proved its importance in the 1840s. Many American doctors dismissed the idea as unnecessary or overly cautious. Germ theory, the understanding that microorganisms cause disease, didn't gain widespread acceptance until the 1880s and 1890s. Before that, most physicians believed in miasma, the idea that illness came from bad air or moral weakness. So they worked without masks, without gloves, without sterilization. They performed surgeries in patients' homes using instruments wiped clean with a cloth. They lanced abscesses and drained infections with their bare hands, and they paid the price. Chronic illness was common among doctors. So was early death. The physical toll of long hours, poor nutrition on the road, and repeated exposure to disease wore them down. Add to that the psychological weight. The farmer who died of lockjaw after a simple cut. The child who succumbed to diphtheria despite every effort. The mother lost to childbirth when everything seemed to be going well. There was no one to talk to about it, no professional support systems, no therapy or peer counseling. The doctor carried the grief alone, then climbed back on his horse and rode to the next call. And the work never stopped. Even in peacetime, the demands were relentless. But during the Civil War, those demands became unbearable. Tens of thousands of physicians served in military hospitals and field stations, operating in tents with limited supplies, amputating limbs to prevent gangrene, watching men die from infections that today would be cured with a week of antibiotics. The war changed many of them. Those who returned to civilian practice brought new surgical techniques and a grimmer understanding of the limits of medicine. But the exhaustion stayed with them. Somewhere in the 1880s, something fundamental changed. It wasn't a single moment. It wasn't a dramatic announcement. But across operating rooms, hospital wards, and even rural medical practices, a new understanding began to take hold. Invisible organisms were killing patients, and cleanliness could stop them. Joseph Lister had introduced antiseptic surgery in the 1860s, using carbolic acid to sterilize instruments and clean wounds. The results were undeniable. Infection rates dropped. Patients survived procedures that would have killed them a decade earlier. But acceptance was slow. Many American doctors resisted, viewing the extra steps as unnecessary ritual or European affectation. By the 1880s, though, the evidence was impossible to ignore. Louis Pasteur's work on microorganisms, Robert Koch's identification of specific disease-causing bacteria. These weren't abstract theories anymore. They were practical tools that saved lives. Doctors began boiling their instruments. They started washing their hands before surgery, not just after. Hospitals adopted sterilization protocols. The white lab coat, introduced in the 1890s, became a symbol of this new era, a visual statement that medicine was now a science of precision and cleanliness, not just instinct and tradition. This was the turning point, not just for how doctors worked, but for how they were seen. Before germ theory, a physician's authority rested largely on presence and reputation. Patients trusted, or didn't trust, based on outcomes they could see, and community word of mouth. After germ theory, medicine gained a foundation of objective, reproducible knowledge. The doctor wasn't just experienced, he was scientifically trained. He understood mechanisms the patient couldn't see. With that shift came new expectations. Medical schools began requiring laboratory work and clinical training. The 4-month lecture course gave way to multi-year programs with anatomy dissections, bedside teaching, and supervised practice. Standards started to tighten. Licensing boards gained power. The chaos of the mid-1800s began to give way to structure. But this also meant something was being lost. The old country doctor, self-taught or apprentice-trained, carrying his leather bag across miles of farmland, making decisions in isolation, was becoming obsolete. The profession was moving toward hospitals, toward specialization, toward urban centers with laboratories and X-ray machines. The solo practitioner, the man who knew every family in town and treated everything from broken bones to pneumonia, was being replaced by a new model. The expert, the specialist, the hospital-based physician. Progress, yes, but also a transformation that would leave an entire way of practicing medicine behind. In 1910, a man named Abraham Flexner visited every medical school in the United States and Canada. He wasn't a doctor, he was an educator, commissioned by the Carnegie Foundation to assess the state of medical training in North America. What he found shocked him. Out of 155 medical schools, many operated out of rented buildings with no laboratories, no libraries, and no connection to hospitals. Some had faculty members who barely understood the subjects they were teaching. Students sat through lectures, memorized information, and graduated without ever examining a real patient. Flexner called these institutions diploma mills, schools that existed to collect tuition, not to train competent physicians. His report, published later that year, was devastating. It named schools. It exposed fraud. And it set in motion a wave of closures and reforms that would reshape American medicine. Within 2 decades, more than half of the medical schools in the country shut down. Standards tightened. Curriculums expanded. Schools that couldn't afford laboratories or hospital affiliations simply ceased to exist. This was progress, undeniably. The doctors who graduated after the Flexner Report were better trained, better prepared, and more scientifically grounded than many of their predecessors. But the reform came at a cost. Many of the schools that closed served Black students and women, groups already facing enormous barriers to entering the profession. Before 1910, there were 7 medical schools in the United States dedicated to training Black physicians. By 1923, only 2 remained: Howard University and Meharry Medical College. The others couldn't meet the new standards, often because they lacked the funding that white institutions took for granted. The number of Black doctors declined sharply. It would take decades to recover. Women, too, saw doors close. Female-only medical colleges, which had provided one of the few pathways into the profession, were absorbed into co-educational institutions or shut down entirely. The percentage of women in medical school dropped and didn't recover until the latter half of the 20th century. The Flexner Report forced American medicine to professionalize. It elevated standards, improved outcomes, and laid the groundwork for the modern healthcare system. But it also concentrated power, narrowed access, and accelerated the shift away from the independent, community-based practice that had defined 19th century medicine. The country doctor, who might have learned his trade through apprenticeship, who worked alone out of necessity, who served populations no one else would reach, was now a relic. The new system wanted specialists. It wanted hospitals. It wanted credentials and institutional backing. The old model didn't fit anymore. By 1920, the landscape of American medicine had fundamentally changed. Hospitals, once feared as places where the poor went to die, were now centers of advanced care. They had operating rooms with electric lights, X-ray machines, sterilization equipment, and trained nursing staff. Doctors who once worked out of their homes now had access to resources they could never have afforded on their own. The house call, which had been the backbone of medical practice for centuries, began to fade. It wasn't a sudden shift. Rural doctors still traveled to patients well into the mid-20th century. But in cities and growing suburbs, the pattern reversed. Patients came to the doctor's office. Or better yet, they went to the hospital, where diagnostic tools and specialists were all under one roof. This made sense. A doctor working in a hospital could see more patients, consult with colleagues, and use equipment that would be impossible to carry in a leather bag. Efficiency improved. Outcomes improved. Medicine became more accurate, more powerful, more capable of intervening in ways that would have seemed miraculous 50 years earlier. But something else happened too. The doctors stopped being the solitary figure who knew every family in town. who had delivered your children and treated your parents and sat at your kitchen table when there was nothing left to do but wait. Medicine became institutionalized, specialized. The general practitioner gave way to the cardiologist, the orthopedic surgeon, the neurologist. Care became fragmented across different experts, different appointments, different buildings. By mid-century, the image of the country doctor riding through a snowstorm to reach a patient's bedside had become nostalgia. It appeared in paintings, in novels, in films that romanticized a simpler time. The Country Doctor Museum opened in North Carolina in 1967, preserving the tools and stories of a profession that had already disappeared. And yet the need for that kind of care, personalized, continuous, rooted in relationship rather than transaction, never went away. In the 1960s and 1970s, the concept of family medicine emerged as a response to over-specialization. It was an attempt to bring back the generalist, the doctor who treated the whole person, rather than a single organ system. But even family medicine operated within the new framework. Office-based, appointment-driven, supported by hospitals and referral networks. The solo practitioner working out of a black bag was gone. The profession had moved on. Today, the United States has roughly 300 physicians per 100,000 people, nearly double the ratio of 1860. We have MRI machines, robotic surgery, gene therapy, and telemedicine that allows a specialist in Boston to consult on a case in rural Montana within minutes. A patient with appendicitis can be diagnosed with imaging, operated on laparoscopically, and sent home the same day. A century ago, that same condition would have meant a kitchen table surgery with a high risk of infection and death. The progress is undeniable. Modern medicine saves lives the 19th century doctor could never have saved. But something was left behind. In rural America today, the problem isn't a lack of medical knowledge, it's a lack of doctors willing to practice there. Between 2005 and 2019, more than 130 rural hospitals closed. Entire counties have no obstetrician, no general surgeon, sometimes no physician at all. Patients drive hours for care that used to come to their door. The country doctor filled that gap not because the system was better, but because he had no choice. He was alone, often underpaid, working with tools that barely worked, but he showed up. He stayed. And communities built their trust around that consistency. Modern medicine, for all its precision, often struggles to recreate that bond. The average primary care appointment lasts 15 minutes. Physicians see patients they've never met before and may never see again. Specialization has fractured care into separate lanes that don't always communicate. The efficiency we gain came with a cost, distance. Some healthcare systems are trying to reverse this. Community health programs, rural medicine initiatives, even technology-driven solutions like telehealth aim to bring care closer to where people live. But the model is fundamentally different now. It's institutional, not individual. Coordinated, not improvised. And maybe that's how it has to be. Medicine is too complex now for one person to know everything. The days of the lone doctor riding out into the countryside with nothing but instinct and a leather bag are over. And they probably should be. But we can still recognize what that profession represented. Responsibility without backup, trust built over years, and a willingness to face the hardest parts of life alongside the people you served. Remember that narrow dirt road in Pennsylvania, 1875. The doctor on horseback, alone, riding toward a farmhouse where a woman is dying of childbed fever. He arrives. He examines her by lamplight. He knows the infection has already spread too far. There's nothing in his bag that will save her. No antibiotics, no IV fluids, no emergency surgery team waiting on standby. But he stays anyway. He sits with the family. He does what little he can to ease her pain. And when she dies, he's the one who closes her eyes and tells her husband there was nothing more to be done. That was the reality of 19th century medicine. Not heroic rescues, not miraculous cures, just presence, continuity, and the quiet burden of knowing that most of the time, all you could offer was your willingness to show up. So what happened to that profession? It didn't disappear all at once. It transformed. Slowly, unevenly, but inevitably. Germ theory gave doctors tools that actually worked. Hospitals centralized resources that no solo practitioner could match. The Flexner Report raised standards and closed the door on poorly trained physicians. Specialization made medicine more precise, but also more fragmented. By the mid-20th century, the country doctor had become a memory. The profession survived, but the model didn't. And yet the need for what that doctor represented. Someone who knows you, who sees the whole picture, who doesn't disappear when the problem gets complicated. That need never went away. We have better tools now, better knowledge, better outcomes, but we're still trying to figure out how to deliver care that feels personal in a system built for scale. How to maintain trust when medicine operates through institutions, not individuals. How to serve the people who live far from hospitals, far from specialists, far from the centers where modern medicine works best. The country doctor is gone, but the questions he embodied are still with us. What does it mean to care for someone when science isn't enough? How do you build trust across the distance that modern systems create? And who shows up when no one else will? Those questions don't have easy answers, but they're worth asking. Because the history of American medicine isn't just about progress, it's also about what we lost along the way, and whether we're willing to find it again.